I'd like to begin this podcast by acknowledging the Turrbal and the Yugara people, who are the traditional custodians of the land on which we meet today to record this podcast. I also would like to pay my respects to their elders past, present and emerging. Hello Academy Associates, thanks for choosing to listen to the Bodytrack Academy podcast, where our aim is to bring clinical research to real-life clinical practice. For further learning opportunities, why not access our educational webinars? To access, click on the link in the show notes. To keep up to date, join our Academy mailing list where you'll receive exclusive content, discounts on webinars and more. Link to join us is also in the show notes.
Hello and welcome to another episode of the Bodytrack Academy podcast. I'll be your host, Dan Harth, and today we have for the first time on the pod, Erin.
Hello,
Erin,
everybody.
welcome. Just a bit of a background for our listeners, Erin. How long have you been at Bodytrack for now?
Just over 6 months, so still relatively fresh,
Fantastic.
which is exciting.
Yeah, very much into new caseloads and new management as well, but I understand you've also got a bit of background before Bodytrack in other work as well. So when did you graduate? What were you doing before Bodytrack?
Yeah. I graduated in 2022 from UQ, but I actually moved to regional New South Wales just for a change of scenery by the beach, which was awesome. So I worked in a multidisciplinary clinic in Coffs Harbour with physios, dietitians, speech pathologists, etc.
Yeah.
Where I gained a lot of valuable experience, especially in that regional setting with different socioeconomic statuses and things like that. But
cool.
Relocated back to Brisbane and here I am at Bodytrack.
Fantastic. And there's no doubt that we've welcomed you with open arms and probably thrown a few tricky cases your way, which is what we're going to talk about today.
Absolutely.
So a bit of a different podcast this time, everyone. We're going to just talk pretty open about a case study here and go through some potential ways of challenging the approach or changing the treatment approach as well, from the suggestions that I have, but also what Erin might have. By no means this is the gold standard. We're just saying what we think on our mind, pretty much. So, Erin, let's take us through sort of the client situation that you've had at the moment, and we can kind of unpack that and go through some of the subjective and objective things that you've been doing.
Yeah, for sure. So I very recently had an initial with this lady in her mid-30s who presented with chronic low back pain that was sort of presenting in her right glute. Now, the nature of this pain is any time she sat on a hard surface, she would just get this excruciating pain. And it's gotten to the stage where she has to carry a cushion around everywhere she goes, to restaurants, movies, you name it. And it's becoming debilitating, and she wants to change and sort of reduce the amount of discomfort she's experiencing. So it was a bit of a complex one, and it is. And I'm still trialing my way through it. Yeah.
What was kind of the main goal out of that too for the client? Was it to basically not have to carry the pillow around and actually just feel comfortable sitting wherever?
So we created a few short-term and long-term goals.
Great.
Our first short-term goal was to reduce the need for the cushion. By enhancing hopefully the strength in her glutes and her hips. We also had a long-term goal of being able to safely and confidently return to Pilates and yoga, as that's something that she previously engaged in and loved. But she noted that she doesn't particularly feel confident and she's very cautious of flare-ups now. And then complementary to that, our second short-term goal was to establish a safe and effective exercise routine because she hasn't actually engaged in strength-based movements over the past 4 or 5 years since this injury has occurred.
Right. So a bit of a variable there that you probably amend and alter with, of course. Just the Pilates and yoga, was it like something where she wasn't comfortable performing it, or had she tried it and it triggered the pain and it flared up pretty much consistently every time? Was Pilates and yoga something that she did prior to the actual pain existing? Like, how did that
she did it prior to the actual injury itself. And it was a progressive injury. So it wasn't that all of a sudden one night she woke up with this pain. It actually originally presented as really bad sciatica. She got it treated, and then she had a very traumatic experience occur in her life, which then caused an increase in pain and increased her sort of pain sensitivity. And then as a result, since then, she tried going to a few yoga and Pilates sessions as she normally would in her routine, but she noted that it was just not working out. She was significantly flared the next day. She wasn't quite sure how to modify the movements. The instructors were a bit unsure as well. So she just didn't feel sort of comfortable anymore.
Yeah. Okay, fair enough. So through that initial assessment, you obviously created those short-term goals, and have you been seeing this client for a little bit of time now in sessions, or
I've actually only seen her once since our initial.
Yep.
So I sent her
Early
home
days.
with early days indeed. I sent her home with a home exercise program after the initial of very basic movements, focusing a lot on diaphragmatic breathing to make sure we've got that control. Movements such as pelvic tilts to mobilize the hips, some glute bridge raises, some toe lifts, and a 4-point kneeling hold. She also has secondary to all of this a shoulder injury that we're mindful of. But yeah, she was noting that since doing our own program, some interesting changes, overall okay, but a few sort of increases here and there of pain, but they settled within the day. So I sort of had to provide that education that this is to be expected. We haven't done any strength-based movements for the past 3 years plus. And so naturally our body is going to have adaptation and change, and that might present in a bit of discomfort, but the fact that it settles is great.
Yeah. Yeah. No, great education there. I would assume as well in this situation, the majority would be your education around managing the pain as well. Had they sought any kind of pain management education before this as well? Was there anything that they brought into the predisposition to the assessment as well?
So they do work in the healthcare sector in the sector. So they do have a really nice, strong base of pain science already, which is great because it means they've already got the baseline understanding, and we can just add to it and develop it. She is also seeing a physio as well, which is great. And I did contact the physio prior to seeing her the second time, and he is also on board with the sort of pain science side of things and constant reassurance and education around different movement patterns.
Yep.
And I believe she is also seeing a psychologist, but I believe that's primarily for her traumatic event, not necessarily the pain.
Yeah, sure. And what kind of pain education have you provided specifically as well? Is there anything that's, analogies that you've used, and has that stuck? I mean, I know it's in the early days, or even if you're preparing to do that as well, is there anything that you kind of have used in previous occasions where there's pain education that you can provide that you found really effective? And do you think that might work for this client as well?
Yeah, I always like using the visual of like their pain threshold. So I'll sort of grab my hand out and put it up maybe around eye level and say, if this is our pain threshold, we want to make sure we're exercising below it, because when we do that, we increase our tolerance, we increase the load and the through our tendons, our connective tissue, our muscles. And then over time, as our body desensitizes, our pain threshold then increases. And I sort of move my hand up to maybe the top of my forehead. And I sort of try and say that if we sort of keep tapping it or go above, it's just going to make it lower. So it's still safe. It just is our body adapting. An analogy that I have not used yet with her, but I have in the past, is similar to our home alarm systems or our sensor lights outside, where it's like when our body is recovering from an injury, it's really sensitive. So if a leaf blew by, boom, the lights are on. We're aware of it. And then as we again increase our load, increase our tolerance, it's as if, a person walked by, now it's on, not a leaf. So it sort of increases in that capacity.
Yeah, cool. Excellent. How did they respond initially to the pain threshold one as well?
It was a little bit tricky, again, because they had that understanding. It was really good in a sense, but it also meant that they were sort of, adamant, like, oh, all good, I already know it. Don't worry about it.
Yeah.
And so instead of having a very straightforward one-on-one discussion about pain science, I sort of had to implement it here and there. So we'd start to do an exercise and I'd say, so this is a really nice example of how, we're only going to do 4 reps initially because that's our starting point. That's our baseline. And then we can build from there and then dive into it that way, as opposed to having that initial sit-down conversation, because we tried that, but it was, obviously wasn't going to sort of get the most out of it.
Yeah,
in our initial.
For sure. I think that's an important point to just focus on for a second, is understanding like prior knowledge as well and bringing that in, but testing where that is. So I think what you've done really well there is actually adapt quite quickly to the situation as well. So, I mean, the analogy that you provided there is, going to work for a majority of the, very simple to understand visuals. That's going to work for someone who's not in the scope of health or doesn't understand as much, right? So the way that you adapted there is a good recommendation as well in terms of actually that's how can we embed this into doing the exercises that they're doing, because ultimately from the client's perspective, they're just thinking as well, the expectation is that they're going to receive exercises to help treat their pain. That's why they've come. They don't probably always think that they're coming to get educated as well.
No.
When they come to see an exercise physiologist. Sometimes they do, but majority of the time it's, well, you're giving me exercises to fix the issue, right? So I think I like how you have integrated the education component within that, the prescription as well. So that's a good tool and tip for anyone about who might be struggling about how they might integrate some education. It doesn't always have to be just a conversation about teaching them with pain education. It can be within an exercise as well. One of the tips that I do from that, I don't suppose I use the pain threshold, but I talk a lot about capacity and load, right? So capacity to tolerate the demands of the load that they're putting on their body.
Yeah.
So similar analogy, but I would say we want to try and approach that capacity as close as possible to incur adaptation and change.
I see.
But as well, at the same time, when we're approaching that, you're asking your questions of not so much, is that painful, but what is your feeling when you're doing that? Or what is it? Is it muscle fatigue? Is it uncomfortable? So you're getting a bit of a scope dependent on the exercise that you're doing as well. So there's some other ways you can broaden the education aspect of pain as well.
So it's more sort of symptom based.
Can be, yeah. So it doesn't always have to be, I mean, it can be obviously vary session to session as well, but it's more so sort of a conservative approach in a way where they might be doing an exercise like say a glute bridge in this example, and that might be, a safe and comfortable level of discomfort they might be feeling, 2 or 3 out of 10 if you're using that rating system, and you're getting them to go for a certain number of reps that's improving that capacity and adaptation close to that pain threshold per se. But it has to be accompanied by questions of like follow-up questions posed, because are we experiencing after that session DOMS, or are we experiencing discomfort, or are we experiencing pain? What is the actual like level that they're actually experiencing from that? So that's what I would follow it up with as well. But that's then how I would see capacity improving, right? So you're not going through those flare-ups, you're improving their capacities, and they can improve so that they can tolerate their load further and then advance further beyond that. So the next time you might do the exercise, it might be up to a high number of reps, or you're adding load to that, and so you're continually evolving from that.
Yeah.
Backing up with follow-up questions about how they responded from that, but also transferring that and transcribing that to what are they functionally able to achieve now as well. Like if you're seeing a direct correlation between increasing their capacity to reducing the need of the pillow, well, you've hit the nail on the head, right? Yeah. So that's kind of how you can broaden that idea as well.
Yeah, I really like that too, Dan, because I think it allows the client to reflect themselves of something that they might not realize of, oh, wait a minute, I was actually able to feel okay after last session, whereas last time I potentially had a bit more discomfort or blah, blah, blah. So it's nice that they can actually reflect, or you welcome that reflection for them in their own life that they might not have. You know, I feel like when you've been living with pain for so long, you don't question things. You just stay,
it's almost
living your life.
Yeah,
exactly.
Yeah, for sure. I mean, we've had countless examples of clients. I mean, not so much within living with pain, but you start the session of how you're going today, and they say, yeah, pretty good. And then you get into the session and like find out they're not performing like they usually would. And it might be that they've had a terrible night's sleep and didn't tell you, or they haven't eaten that morning. They're feeling dizzy. And you're like, this is why you need to probably do a little bit of that subjective analysis at the start and inform them, because they don't kind of realize it themselves as well until they feel that symptom or have that trigger to go, oh, actually, it is better, or this is why this is happening to me. So, no, but good. I think in terms of the education aspect that you provided, sounds like it's going pretty well. it's probably, you're preparing for what's to come next as well. What's the response like from the intervention you've started with? What's the next step going forward from there? And it sounds like you've got a few things to progress toward, specifically with the exercise prescription. So I think you mentioned it before, but go through the first couple of exercises that you prescribed for this case.
Yeah, so her home movements, which I gave it straight away after the initial just to get the ball rolling a little bit. We have some pelvic tilts in there, again, because I just wanted to make sure she had that pelvis mobility, but also that connection to actually be able to feel her body move.
Sorry to jump in, but is that how you explained it as well? Of like, when you're delivering exercises, are you going, this is why I want to prescribe this, so you can feel...
Yeah. And I think especially in a case like this, it's very important that they feel understood and heard. And so if I was just to say, oh, we're doing this, this and that, she's had a history of going to Pilates and yoga and not feeling heard and then having a flare up, etc. I want her to feel in control and fully understand what we're doing and why we're doing it. Yeah. And I think that in turn also helps with their adherence, but also their sort of response to the movement. They're not hopefully as scared to complete it. It's, I'm doing this to help strengthen my glute or to help mobilize my hips. Yeah, exactly.
So basically, you're pretty much going along the lines of ensuring that the patient education is there as well. So it's not just reliant on yourself to fix the issue.
No, yes, it's a team effort.
And you're empowering them to understand and join the two together, etc.
Yeah.
In the Pilates yoga, I know I'm tangenting a little bit, but in the Pilates yoga, was it group based?
It was, yeah. So it was just
not a personal.
No, it was your sort of stock standard group class. Maybe 12 to 20 people with a Pilates yoga instructor, etc. Yeah, but it was generalized healthy pop.
Yeah, so you can kind of like almost paint that picture really of client's journey there in a way. And I'm going to speak very broadly here, but it seems to me like they have tried to stay active and fit as possible and strong as possible through those means, but they have been group means. And so the pain has obviously exceeded to a point when change needs to happen, and they've chosen the personalized approach, which is yourself and to yourself. So you can kind of look at it and go, well, what are the variables that you can tinker with? Because that's often what I face as well with clients is when they come in, what's the variable that's missing? What's something that we can change and have an impact on? Because there'll be people coming in saying that they already exercise. What does that exercise look like? Is it just walking? Is it a higher intensity exercise? Is it resistance training? What means of resistance training is it? Are they doing it by themselves? Have they already seen someone else? So there's so many different variables that you can look at and go, well, with my professional input in this, that's what I can change so I can really focus and ramp up the strength training. Seems very simple from our aspect, from the client's aspect. It can be life-changing as well. So that's another way that I like to break things down as well, is look at what are all the things that this person is doing and what is missing, and then alter the variable that is there. But anyway, back to your exercises.
Yes, no, that's okay.
I love my tangents, and I'm sure everyone on the podcast knows this, but we started with the pelvic tilts.
Yes. And then we go into some breathing. So diaphragmatic breathing. So I've just got her placing one hand on her chest, one hand on her lower abdomen. Yep. I'm sort of going through that. We're going for up to 5-second holds. I did also provide her with a link to a really nice sort of like 4-minute deep breathing breath work, link that Georgia recommended for endometriosis clients, which is awesome. Great. So I sent that all across to her.
Yeah. What was her response on that?
She really enjoyed it.
Yeah.
Because she's doing a lot of that with her psych at the moment. So she was really happy. She's like, oh, the more, the merrier. Like, I love hearing different
really
approaches.
Bought into the process.
She really she valued having that link.
And how did you kind of link that to what her persistent issue was, or what she came in with as well, and towards her goals as well?
I sort of explained the importance of the pelvic floor through movements, especially in sort of our hip region. And again, I actually had a chat to Georgia about a different client, and she was mentioning that there's now new research coming out that some pelvic floor tightness or hypersensitivity can present as hip pain. And so I thought, we'll just incorporate that, because regardless, I want her to be sort of calm and focused during the rest of her movements. So I wanted to put it at the start. And then too, I think it's a great way, to control her breath, control her pelvic floor. And then we start loading sort of the glutes, the core, etc. Because we go into some glute bridge raises, some supine, toe lifts. And then I think our last exercise are our 4-point kneeling holds. I think that's all that we've got at the moment. Yeah.
Great. So I would say from those other exercises that you've given the education around how it links back to how it's treating their symptom and their goals is pretty much what you've already explained. Like you're just linking it back to that pain threshold, building capacity, understanding body awareness, those kind of things.
Yeah.
Cool. Quick side note for those who are new to the podcast as well, Georgia has done a few podcasts around women's health topics. You can find them through our list.
Yay, go Georgia.
So going forward, has there been any major challenges, or even, I know it's only been a brief period, but is there any challenges that have stood out to you at the moment in terms of the progress that you want to make with this client?
Yeah, for sure. The first one is probably she's extremely smart. She's very hyper aware.
Yeah.
So she's extremely vigilant with her pain. When she's working from home, she sort of sets a timer as, all right, now it's my time to stand. Now it's my time to sit because of my hip. And so it's tricky.
So that could be regardless of actually the pain as well.
Yeah.
Is that what you're thinking?
Potentially. Yeah.
So it's almost like a routine regimented clock.
I think so.
Yeah.
She's very, it's great. She's really descriptive with her pain. She knows exactly when it's happened on these days and that. But in turn, if we're sitting at home thinking all day, oh, how am I feeling right now? Is my hip sore? Of course it's going to be sore because we're thinking about it 24/7. And so I think one thing that I'm yet to sort of explore, and I will as we sort of build client rapport and I see her more regularly or more frequently, is tap into that and go, oh, what do we do at home in our spare time? Are we just sitting home thinking all day about our pain, or are we distracting ourselves? And I think I mentioned this earlier, but she actually plays a sport once a week as well, a social sport, and she has no dramas with any pain, discomfort in her hip or her lower back. She's able to run, jump, change direction, etc. She's happy throughout, happy after. And so,
what are your thoughts on that?
I think it's tricky. I think it just goes to show the power of social settings. Yeah, and distraction. And of course, when we're at home and we've had a rough day or we have had a stress at life, and of course she's already overcoming this significant stress that she's experienced. Naturally, we are going to sort of think, oh, I am quite sore, oh no, and it's just going to snowball. But I, again, tried to encourage her, explaining that that's a huge step, the fact that she can do that. She can jump, she can run, she can move side to side. The fact that she can do all of those plyometric sort of, return to sport and rehab movements safely and feel okay. Just providing that encouragement that this is a great starting point and that we will get better. We'll just have to take our time. We've got time's our friend. Yeah.
I think one of the challenges you might face there, Erin, is
Hello again. Thanks for taking the time to listen to our podcast. Another shout out to a sponsor that we have, the Barbell Jack, where you can master your lifts to save time, energy, and lift like a pro. The Barbell Jack isn't just any gym gadget though. It's your new best mate, designed to ensure a safe posture when changing weight plates. This is a must-have in your clinic. Embrace the power of professional lifting techniques and hit your personal records with ease. Use the code BODYTRACK to receive 10% off your order. Now back to the podcast.
sort of how you link that and educate it, because it's just, again, correct me if I'm wrong, but it is sounding like that hyper awareness, hypersensitivity is driven from when they're trying to kind of say, for sake of a better word, fix the issue of what the issue might be, and like what is this issue that kind of exists, and that might be psychologically driven as well. Because then you can quite easily paint a picture and go, well, you're doing plyometric increased forces. You could go into the whole part of there's a significant increase in load going through that area, which if you had a really, you had a really severe diagnosis, or you had something that was really quite structurally maladapted, then it would make it worse. So I think and then they've also got health literacy, they've got pain education tolerance. So I foresee a bit of a challenge.
Yes, I do agree. And I love your opinion. My current plan was just to sort of maintain or continue to build that client rapport before I sort of explore that.
Yeah.
Because I think I really don't want any client to take it as I don't believe them, because I do.
Yeah.
They are definitely experiencing this pain.
Yeah.
And it's complex.
And so it's validating them. Yeah,
for sure. So I just want to make sure that she still feels heard.
Yeah. I don't think for say, like, apologies if I went down that track, but it's not so much that they're not feeling that pain. It's just, on one hand, you've got them coming in to do treatment. And even I find this, even when people come into the clinic, like, it's just merely stepping into an exercise rehab clinic, which is what they might see us as, already a negative connotation or negative stimulus on what their pain might feel, because we know biopsychosocial model applies all the time.
Yeah.
This. So psychologically, are they coming in and actually subconsciously, consciously going, okay, Erin is the practitioner, the health practitioner. I have to tell her all my painful episodes, my symptoms, my experience, my flare-ups and stuff. So is that already having a negative impact? I'm not certain. Whether that's that could drive a lot of it, but I find that with my clients as well. There is a sensation of even going to a place where they feel they have to be fixed. It may actually produce those hyper-awareness symptoms, be hyper-awareness and hypersensitive in those moments as well. And I would say you could apply that same thing to the home, working from home and 30-minute regimented clock of getting up. Is that just a regimented thing that they have adopted? Why did that start? Who told them that? Is it themselves? There's some things that you can explore there. Because then you go to the other end of the spectrum, and they're jumping around on a social sport and having a lot of fun. And is that joy and that enjoyment and the feeling of actually being able to participate in such sports, the social engagement, is that just completely nullifying any of the symptoms of pain that they might experience as well? So, yeah, it's a bit of a different.
It is. And I'd also just like to note quickly, you didn't talk on sort of that structural, if there was actually anything structurally malaligned or whatnot. And the physio did explore that route, and she has been cleared from all her scans. So, there's no clear sort of structural cause or biological, if you think of our biopsychosocial model. Just so that the listeners know
interesting scope. So let's wrap it up with, I guess, exercise prescription wise. Is there any potential progressions like you've already planned out? What, I guess, encourages you then to prescribe a progression of the exercises? When do you know that the client's going to be ready? Is it from them subjectively? Because we may find some discrepancies there, as we've just discussed. But is it from them subjective, or are you watching movement patterns? Are you looking at, are they able to tolerate that intensity? What kind of goes through your progression plan there?
I definitely am taking the more subjective approach originally with her, just because, again, I want her to feel in control and sort of allow her to understand how to listen to her body.
Yes.
With the support of myself as of an exercise physiologist. Through her objective testing, there were a few discrepancies through her hip range of motion.
Okay.
And so, especially through her abduction and then her internal rotation. So I am planning to layer in some more abduction work, whether that's like standing hip abduction. How many times can you say abduction in a sentence? And movements like that, even potentially a flamingo hold against the wall, but just with body weight, not worrying about sort of a cushion or whatnot. But I am guided by her subjective nature. At the moment, our reps are quite low, so we're doing 2 sets of about 4 to 6 reps because that's all she can tolerate at the moment, which is okay. That's our starting point.
That subjective response is what you can tolerate?
Yeah.
Gotcha.
But it is also going to be based on, actually, I was a little bit sore that night, but the next day I was okay. Great. Now let's progress. At the moment, it's still sort of early days, murky waters. We're still finding that baseline, of course, because I've only seen her once since the initial. But that's the approach I'm trying to take with her. Yeah.
I think feedback from that, a great route to take. You need to build that rapport, therapeutic alliance with them first. And I like the fact that you're giving them control, because they would come to not be told exactly what to do. You have to have that professional guidance, but also balanced really well with including them in that treatment plan, the holistic care, patient in the center, everyone around. So yeah, I think that is good. I would be interested to see, when that flicks over to say you going, okay, I think you can progress in this. Yeah. So it'll be interesting to see at what time point that happens. And that's going to be different for everyone as well. It's not like, all right, rapport's built.
There's no cut.
Yep.
Cut
okay,
week.
Now listen to me.
Yeah. At a 6-week mark, it changes. Yeah.
But yeah, I think the approach you're taking is the right way to do it. Build the therapeutic friendship and the rapport that you have to then get them to buy into the trust and the process. And then, I mean, you might find that they still are sticking at that 4 to 6 rep mark because that's what they've been told to do from you.
Yeah.
But can they actually go to 8? Can they go to 10, 12? Or can they change the exercise to make it more challenging so that they're building that capacity, pushing that pain threshold further, as you alluded to earlier?
Yeah, for sure.
Yeah, I think there's potentially some of the interesting challenges we have coming up. Education about that discrepancy of, well, you're playing social sport, but you're very hesitant or cautious in your movements at home and with me. That could be potentially one, but then, knowing how to pull the lever and when to progress further when they are ready to.
Yeah.
So, any final points from you?
My last point, I'll probably just put out there, the other bit that I am sort of cautious of moving forward is I do want to trial slowly decreasing the cushion sort of thickness and sort of progressing potentially to a towel or a thinner foam pad. And I'm still unsure when I'm going to sort of start to initiate that. But I think that exposure and desensitization is very important, especially when we look at her goals. Yeah. And hopefully her strength training will complement that. Yeah. But I think, and just another tricky one.
Yeah. To navigate as well. Yeah. Just quickly on that too, is that your goal for her or is that her goal?
It's my goal. Yeah. So
that's another challenge.
It is. Yeah. Because overall, her main goal of coming here was to not have to take her cushion everywhere. Yeah. She's just sick of it, which is so fair.
Okay. All right.
And so, although she would be all for it, I'm sure she's become reliant on this cushion for the past 3-4 years. Yeah. It's going to be a huge barrier. It's going to be so scary.
That's good. At least there is some buy-in there from her. I thought it was more so like,
me just saying,
no. Saying, yes, I do.
No.
So, but no, if they're a bit more open to saying, I do want to kind of wean off using the cushion, the reliance on it, then you got your way in there. But yeah, I think it'll all culminate into coming together at probably a similar time, or when you probably can take a bit more of a lead in the progression of exercise prescription. But you hit the nail on the head. Rapport building is the first, and trusting you is the first step that needs to happen. And it's too early days at the moment. Yeah. I've seen them just once and, due to see them. When do you see them again?
I see them weekly at the moment. Yeah. So I'll see them next week in a few days.
A bit more frequency now.
Yeah.
Very interesting. We might follow up on this.
We should. We should indeed. Yeah.
Wednesday night.
Yeah.
On that note, thank you very much, team, for listening, and stay tuned for more from the Body Track Academy. Enjoy.
Thanks for listening. We hope you enjoyed this podcast, so remember to share, like, or follow to keep updated with all our podcasts and educational resources.